We are live.
Very good evening, everyone, and I welcome you to the last case presentation webinar before we jump into attending MOSCON, which is in Goa this year. And we shall resume our programs again after the annual conference. So in the meanwhile, this last one is again focused on congenital disorders. Excellent curation by Professor Varu, who's a member of the scientific committee, and Dr. Sumit Lane. We have two cases. The first case is going to be by Dr. Romik Soram, who's a JR3 in the Government Medical College of Kolhapur, and she has been ably mentored by Professor and Head Dr. Satish Desai from Government Medical College Kolhapur. The second case is going to be by Dr. Sadia Sheikh, who is a third-year DNB resident at Sri Ganpati Netralaya in Jalna, ably mentored by Dr. Yogesh Jaibai, who's a consultant in the Department of Pediatric Ophthalm at Ganpati Netralaya in Jalna. We have two expert panelists with us today who are going to fulfill the role of examiners. My dear friend, Dr. Vivek Warkad, who's a consultant in pediatric ophthalmology, strabismus and uro-ophthalmology at LVPI in Bhubaneswar, and Dr. Mona Sunekondare, who's has a long career span of 19 years in teaching and now director at Sune Eye Care in Varda. So with this, I hand it over to Dr. Vare to please take the session forward.
Yeah. Good evening, everyone. So today we have two interesting cases. The first case is by Dr. Romik, and she'll present a case of congenital cataract. And the second is by Dr. Sadia, and she'll be presenting a case on refractive amblyopia. So both the cases are very important. So each participant will have 30 minutes, and they'll have around 10 minutes for presentation and 20 minutes for examination. So I request Dr. Romik to share her screen and start presenting.
Ma'am, can you see my slides?
Yes, we can see your slides.
Good evening, everyone. I'm Dr. Romik Soru, junior resident. I'll be presenting a case of developmental cataract. First of all, I would like to thank my mentor, Dr. Satish Desai, sir, associate professor and head, and my institute, RCSM, Government Medical College, Kolhapur, for giving me the opportunity to present a case on such a prestigious platform. So moving on to the case. A woman being the mother, an 8-year-old male child was brought to the ophthalmology OPD with complaint of reduced vision in the left eye, which was screened during a school health program 6 months back. History of presenting illness: reduced vision in the left eye, which was painless in nature, insidious in onset, screened during a school health program 6 months back, and was referred from there for further evaluation and management. There is history of constant outward deviation of left eye, which was first noticed by the parents when the child was around 1 year of age. Negative history: there is no history of spectacle use, no history of trauma, no history of chronic use of eye drops, no history of diplopia, drooping of lid or abnormal head posture, no history of abnormal or any jerky movement of the eyes, no history of seizure, deafness, diarrhea, and vomiting. Antenatal history: all trimesters were uneventful. There is no history of intake of any drugs or exposure to radiation, no history of fever with rash, no history of trauma. On birth history, mother has undergone elective LSCS at birth. Place of delivery was hospital. Birth weight 2.6 kg. There was history of NICU admission for 2 days for neonatal jaundice, and after that, there was uneventful postnatal period. Milestone attained at appropriate age. Immunization was complete as per schedule. On personal history, diet was mixed, appetite normal, sleep normal, bowel and bladder habit normal. Family history: there is no history of consanguineous marriage in the family, no history of similar complaint in the family. On general physical examination, patient is conscious, cooperative and oriented to time, place and person. BMI was 22, vitals were normal. On head-to-toe examination, there was no evidence of pallor, icterus, cyanosis, clubbing, edema, or any preauricular lymphadenopathy. Systemic examination was within normal limit. On external examination, facial symmetry was symmetrical, head posture straight ahead, forehead was normal, extraocular movement full range in all direction of gaze. On Hirschberg reflex test, there was left eye 15-degree exotropia. Moving on to the ocular examination. First of all, right eye visual acuity, distant vision was 6/6. Yes, ma'am. Near vision was N6. Anterior segment of right eye was within normal limit. Left eye distant vision was PL and PR accurate. Eyebrow, eyelid, eyelashes, palpebral aperture, and conjunctiva of left eye was normal. Then cornea, normal size, shape, surface, shiny, transparent. Anterior chamber, normal depth and content. Iris was color pattern normal, and pupil was single circular central. Size was normal, and light, direct and consensual light reflex were present. On examination of lens, left eye there was central nuclear cataract with clear periphery and riders towards the equator. IOP both eye was 18 and 16 millimeter of mercury, and Rho plus was negative. Then on distant dilated fundus examination, first of all on distant direct ophthalmoscopy, right eye showed good fundal glow, and left eye fundal glow was seen from the clear periphery. Then right eye fundus was normal, and left eye fundus viewed through the clear periphery appeared normal until visible. So my differential diagnosis are developmental cataract, congenital cataract, and sensory exotropia. My provisional diagnosis is 8-year-old male child with left eye developmental cataract with 15-degree sensory exotropia with amblyopia. Investigation, routine blood investigation and chest X-ray PA view along with anesthesia and pediatric fitness were obtained. Plan of management. Child has undergone left eye phacoaspiration with hydrophobic IL implantation under guarded visual prognosis under anesthesia. Further plan of management, refractive correction and amblyopia treatment post-surgery. Biometry. SRK-T formula was used with 10% under correction. These are the biometry details. Surgery was uneventful. Then on post-operative day 1, left eye vision was counting finger half meter. There was no acceptance to refraction and fundus was within normal limit. Amblyopia treatment was started right after surgery. Patching of the better eye for 6 hours a day along with near work activities were advised, and assessment will be done after 10 weeks from the onset of treatment initiation. On post-operative day 7, vision was counting finger half meter with pinhole no improvement. Retinoscopy was done with 2% homatropin at an arm distance. Right eye, there was 0.5 diopter sphere, and left eye, 0.5 diopter sphere with +1 diopter cylinder at 90 degree. Child was, even though there was no acceptance, child was given retinoscopic spectacles. Child was given spectacles, ma'am. Thank you.
Okay. Very good presentation. Are you done?
Yes, ma'am.
Okay. You wanted to show the previous slide again?
Ma'am, this to our squint assessment.
Huh.
Squint assessment was done on POD 7 as well as on POD 1. So on word for dot test for near, all 4 dots were seen. And on cover and uncover test and alternate cover test. First of all, on cover test, on covering the right eye, left eye took fixation. And in case of uncover test, which is to unmask phoria, on unmasking the apparently fixating eye, the right eye goes out from center to periphery. And on alternate cover test, both eye alternate fixation was seen. This is the video. Yeah, thank you, ma'am.
Okay. So very good presentation. Will you please stop sharing your screen now? Okay. So congratulations, Romik, and congratulations, Desai sir, for presenting a very good case. And now I request Dr. Vivek sir to ask questions to Dr. Romik, please.
Yeah, so thank you so much for opportunity, and Thanks, Romik, for bringing up very interesting case of the pediatric cataract. So I noticed a couple of things before I point them out. I just want to ask you, three questions first. Then we'll have an interaction, and then I'll bring out, a few points where probably we could have been even getting better information. So, why did you ask, the history of trauma or radiation exposure? Question number one.
Sir, first of all, it was a unilateral cataract. So that's why I have asked history of trauma, sir.
Okay, so yes, I mean, for unilateral case, I think the most common cause we should think about is, particularly in pediatric age group, is trauma, and for that matter, even the radiation exposure. Probably the patient had some sort of malignancy and having exposure on that particular site. So that could be also one of the cause for developing the cataract, number one. My second question was, what was your thought process when you assess the vision and you notice that, there is a PLPR vision, there's very gross loss of vision. So what was your thought process once you, because, when we evaluate the child, it's all about demography, then history, then visual acuity, then anterior segment, posterior segment. So as we keep on moving in this sequence, our thought process keeps on changing, right? So you know that this is demography, this is the history, and then now you came to know that, oh, PLPR. So what was your thought process? What differentials you would add at this time point of history, apart from, the anterior segment, and then later on we did a posterior segment examination. So at this time point, what are the differentials that were running into your mind?
The vision was only PL and PR. This signifies the severity of the condition. So planning and intervention has to be done as soon as possible.
So what
So,
severity of condition you would anticipate in a child with unilateral pediatric cataract?
sir, I didn't get your question.
See, this is a case of unilateral cataract. There is a gross loss of vision. If it is a central nuclear opacity, right? If it is a lamellar variety, we usually don't anticipate such a gross loss, right? Especially in a
Okay, sir.
metal cataract,
Mm.
isn't it? So
Yes,
what
sir.
differentials you would think when there is a unilateral cataract with a very gross loss of vision, like a PLPR in your case? That's what I'm asking.
Sir, I will suspect the insult has been it has been way before uh, my anticipation. So it could lead to amblyopia, sir. One differential diagnosis is
So,
amblyopia.
so that's exactly, you are on a correct point now. It's a dense amblyopia.
Yes.
So apart from that, I just, to save the time, I just want to add, dense amblyopia, what you would first think. Then there could be an underlying PHPV cataract, being unilateral and pediatric age group. There could be a posterior lenticonus, isn't it? Or
Yes.
there could be underlying uveal coloboma, or something which is gross that is happening since birth, some sort of anomalous posterior segment. So these are the differentials you would think, or sometime, if it is a bilateral, because you have an opportunity to see the normal eye. If that eye disc is normal, you anticipate probably this is normal, then these are the differentials. If other eye is a pale disc, then you would anticipate something gross being a bilateral disease, like, hypoxic ischemic encephalopathy. So those things will be added by your history, like, compromise perinatal period,
Yes.
low birth weight, prematurity, long admission in PICU and all those things. So these are the four differentials that you would think about. Now, my third question and last question. In this case scenario, when you were not able to see the fundus, what investigation you would do it?
Sir, fundus, I was able to see the fundus through the clear periphery. I
Yeah,
was
so
able to see the
that would
disc.
not give you a real picture, right?
Yes, sir.
That would not give you the real picture when you are
Okay,
able to
sir.
see the periphery. So what investigation you would do?
Sir, to rule out the posterior segment pathology, we should go for P scan, sir, USG scan.
Before that, which is a very good clinical tool that is very much handy in our hand. Pupillary reaction.
Okay, yes. Yes,
Right.
sir.
So I think pupillary reaction is very, very important. That's $1 million test, which can very
Yes.
easily be done. So yes, you are
Mhm.
right. So B scan is extremely important. And believe me, in LV Prasad, irrespective of whether, there is a non-dilating pupil, hazy media, in children, it is always better to recommend, the B scan in both eyes. Okay, that's a good practice in pediatric age group. There is no harm in ordering B scan and to have a baseline documentation. Sometime why I'm saying this, because we do miss, apart from very gross posterior segment pathology, there is a one variety of PHPB that's called as a peripheral PHPB, where you would find, elongated ciliary processes or a fibrous band which is coming from periphery and touching to the center of the lens. So I think these are the three questions from my end I wanted to ask. I think you did pretty well. Now the point which I wanted to highlight is you said in the slide you mentioned DDs. They are not DDs. That is your diagnosis, right? The sensory exotropia is a diagnosis. It's not a differential diagnosis, because you know that there is a loss of vision. There is a dense stimulus deprivation amblyopia, which could lead to the sensory exotropia, right? And then it is good for the patient, the post-op, the fundus was normal. So that itself proves that probably we are dealing with a case of dense unilateral stimulus deprivation amblyopia, that you need to prognosticate this patient before you take them for surgery. That's the importance of counseling before you operate them. That's all from my end, Dr. Vare.
Thank you, sir. Thank you very much. Now I request Dr. Mona to ask questions to Dr. Romek, please.
Nice presentation, Romy. Vivek sir already asked you very, very important and already projected the important findings. But I just want to ask you, you have already mentioned, but what is the morphological type of your cataract?
Ma'am, nuclear cataract. It was a type of zonular cataract, ma'am, which is a type of nuclear cataract.
Uh, you must be knowing all the different morphological types, right?
Yes, ma'am.
Can you name them?
Morphological type, it is classified into anterior, posterior, nuclear, cortical, then uh, uh, then total cataract, then mix variant, ma'am. Then cataract with posterior capsular dehiscence, cataract with
Yeah, okay. My aim to ask this question is basically if it alters your management, this morphological type,
uh,
does it, have you heard partial cataract? Because you are presenting the congenital, no?
ma'am,
Does it
it's a
alter,
developmental cataract.
yeah. Does it alter the management?
See,
Yes, ma'am. Ma'am, depending on the size of the cataract, if it does not obscure the visual axis, then we can wait and watch. If it obscures the visual axis, then we have to manage as soon as possible, ma'am.
What is the criteria? Is there any criteria in millimeter of the lens or
Ma'am, if the cataract is central, it is there. If it is dense, size more than 3 millimeter, then it is an indication to plan for surgery, ma'am.
okay. Why? Again, why?
Ma'am, it can lead to stimulus deprivation amblyopia, ma'am.
Criteria, right, right. So you said it's a 8-year child. Your child is
Yes, ma'am.
8 years. Okay. So why you kept one diopter of hyperopia? What is the need?
Sir, ma'am, I didn't get your question.
Target residual refraction, you said one diopter of hyperopia.
Ma'am, after post-surgery, the refraction was 1 diopter. Actually,
Why keep this hyperopic thing in children? Is there any need?
ma'am,
Child is 8 years. If the child is 5 years, what is the need to keep the hyperopic refraction? Residual
ma'am, in order to, ma'am, under correction is done in order to accommodate for the growing eyes, ma'am.
Yes, the eye is constantly growing, and with the growing age, there is always myopic shift. So,
Yes, ma'am.
have you heard the rule of 7?
Yes, ma'am. Rule
What
of
is
7,
that?
ma'am, it is for
Yes.
sulcus placement, no, ma'am. Depending on the effective lens position, ma'am.
No. Rule of 7 is for IL calculation. As you said, no, the eye is growing.
Uh,
So, up to what age you expect this myopic shift or growth of the eyeball?
Sorry, ma'am, I cannot recall. Rule of 7.
Because you are dealing with the childhood cataract, congenital or rule of 7 cataract. If the child is at 1 year, so what refraction you will, what IOL placement you will be doing?
Ma'am, your voice,
Okay, you can't hear me?
ma'am, I can hear you now. It was not clear before.
Okay. Why? I just want to know that why you want to keep hyperopic refraction, residual refraction after IOL placement in children below the age of 8 years.
Ma'am, as the child will grow, the eyes will shift, have a myopic shift, ma'am. So,
So that is the rule of 7. Basically, it is the sum of age of the child and residual refraction. If the child is of 1 year age, then you have to keep target refraction of 6 diopter plus 6 diopter. Okay, it's like that. 1 plus 6 is 7. So that if the eye is growing till the age of 8, 9, 12 years, then that IOL will be matching that, will be to the emmetrope or slightly myopic side. Okay. Okay. I think you have done well. I think IOLs are basically used in, and what is the age? If the child is less than 1 year or 2 years. Hello,
yes, ma'am.
can you hear?
Yes, ma'am, I can hear you.
What is the preferred age for IOL implantation?
Uh, Ma'am, infant aphakic treatment study has cautioned use of IOL less than 1 year of age. So we can, above 1 year of age, we can implant IOL, or if the corneal diameter is more than 9 millimeter, ma'am. In absence of other indications are in absence of microcornea and microphthalmos, ma'am.
Yes.
And also, ma'am, in absence of active inflammation.
What is the commonest complication in congenital cataract after surgery?
Most common complication is visual axis opacification, ma'am, seen post-surgery.
Any other?
Ma'am, there might be refractive surprise.
That is expected. We are already dealing with it. How will you rehabilitate the child if it is aphakic or if it is pseudophakic? Kept pseudophakic or aphakic after surgery?
Ma'am, in case of pseudophakic, we have to give correct the residual refractive error. And in case of aphakic, either we have to give aphakic glasses or we have to give contact lens, ma'am.
What you will prefer in infant below 1 year?
Ma'am, contact lens, ma'am.
Okay, I think this is done from my side. Okay.
Vivek sir, would you like to ask anything else?
Yeah, I think both of us has covered most of the common questions. Probably any resident they would get when they face the Viva, because these are all very common questions. Apart from that, I just wanted to highlight, like, for the broader audience or residents who are hearing us, I think what we have highlighted through this particular case presentation is when there is a unilateral cataract, we have learned we don't need to investigate much, unilateral. So you look at locally what's happening. Okay, if there is B scan is one of the very easy tool. Most of the time in unilateral cataract, you would find something ocular cause of cataract, apart from the congenital. Although congenital cataract or a developmental cataract by convention they are bilateral, but we do come across unilateral developmental or a congenital cataract. Apart from that, as a routine battery of test, I think torch profile still in Indian context is a very, very important tool to investigate this group of patients. Otherwise, for bilateral, again, history is very important. You always ask whether it is, autosomal dominant or autosomal recessive. So that helps. If it is an autosomal dominant, then that's a familial variety. You don't need to really investigate them much. What we are left with is, if it is not autosomal dominant, then you try to investigate and look for other the syndromic and non-syndromic association. This is in terms of the etiology and picking up and investigating them. Another important point which Dr. Sune tried to highlight is the calculation of IOL power. It's very, very important, which is in a pediatric age group, especially when less than 7 year, the INEDI's rule of 7 that we all follow it up. So you have to undercorrect the power for the growing eyeball to match with the hyperopic refraction. So rule of 7 is what most of us do practice. Many practitioners, they undercorrect by percent depending upon the age. So that is very important. Then in pediatric age group, we should always use hydrophobic acrylic material for implanting these IOLs, which I wanted to highlight. And again, last but not the least, most important part of pediatric cataract surgery is post-operative rehabilitation. So I think as Romik has very aptly said, as per the infant aphakia treatment trial, the cutoff for taking a call for putting the IOL is 1 year. But these studies are like almost 2 to 3 decades old now. The practice has been changed over a period of decades. So in my practice, I put the IOL as young as 3 months, 6 months. Having said that, you have a very good horizontal corneal diameter and on table intraoperative good bag. Sometime, many time the cornea looks small, like 10 millimeter, but you have a very good bag. So I think IOL in the bag is the best rehabilitation. Believe me, that's the best rehabilitation. But for a number of reasons, if you can't do it, then high plus post-operative glass and contact lens, these are always option. But contact lens, the practical aspect in Indian context is literally difficult, to really maintain those contact lens, especially in children's. So there are a couple of studies which shows there is no much difference in terms of using high plus power versus contact lens in terms of recovering the visual acuity over a period of long follow-up. So I think high plus glasses are equally good as to that of the contact lenses. Then the pseudophakic, yes, as she said, as per the undercorrection, we should follow them up on early age, every 3 month under anesthesia, or as they grow up every 6 months, as depending upon the child's cooperation, and look at the matching with the undercorrection with the age. We have undercorrected, let's say, for example, at 1 year, 6 diopter. So at 3 years, whether that refraction is matching or not. So that helps us. And sometime if you are, nicely documenting it, then sometime it helps to pick up the glaucoma. The rapid myopic shift is a sign of underlying glaucoma. That's how the importance of detailed examination under anesthesia in terms of HCD and axial length, that adds value to pick it up glaucoma early and treat it. So that's what I wanted to add, which was not being discussed in depth.
Thank you so much, Vivek sir, for your invaluable inputs, and I'm sure they will benefit all the residents who are listening to this webinar today. So with this, we will move on to our next case, and the next case will be presented by Dr. Sadia Sheikh, and she will be presenting a case of refractive amblyopia. And she is a third-year DNB resident from Sri Ganapati Netralaya, Jalna, and she is mentored by Dr. Yogesh Jaibhai. So I request Dr. Sadia Sheikh to share her screen and start presenting.
Yes, ma'am. Good evening, everyone. I am Dr. Sadia Sheikh from Sri Ganapati Netralaya, Jalna. I would like to thank my mentors who have given me opportunity to present here. So, a 17 years old male came to the OPD with the chief complaints of diminution of vision in the left eye since 6 years. History of presenting illness. Patient was apparently all right 6 years back when he accidentally discovered diminution of vision in the left eye on closing the right eye, which was not progressive and not associated with any aggravating and relieving factors. There is no history of drooping of eyelid, no history of deviation of eyes, no history of medications used in the past, no history of frequent redness or rubbing of eyes, and there is no history of trauma. Past history. There is no history of ocular surgeries performed in the past, no history of previously used glasses or the contact lenses, no history of any therapy or the exercises performed in the past. Birth history. Patient had normal vaginal delivery with a 2.5 kg birth weight without any intranatal and perinatal complicating factors. There is no history of NICU admissions after birth. Family history, there is no history of use of glasses in the family. Systemic history, there is no history of seizures or any other systemic illness. Vision, now coming to vision and refraction. The uncorrected vision, which is checked with the Snellen's chart, is 6.6 in the right eye and it is CF 1 meter in the left eye, which is improved to 3/60 with pinhole. Refraction done with the retinoscopy in the right eye is plus 0.75 diopter and in the left eye it is plus 5.75 diopter. The patient accepts plus 3.5 diopter and the vision improved to 3/60. The near vision, which is checked with the Jaeger's chart, is N6 in the right eye and it is less than N36 in the left eye. Cycloplegic refractive value in the right eye is plus 1.5 diopter and it is plus 6.5 diopter in the left eye, but the vision remains 3/60. Coming to light reflex test, Hirschberg test, which is performed with the help of pen torch held at a distance of 1 arm's length. Here, in both the eyes, the reflex was central and central cornea reflex was same. Bruckner's test, which is performed with the help of direct ophthalmoscopy, reveals more brighter reflex in the left eye than right. Sensory evaluation. Worth 4-dot test reveals separation of the left eye for both distance and near, which is again supported by Bagolini striated glass test, which also shows separation in the left eye. Motor evaluation. Ocular motility is full and free in all the directions in both the eyes. The 4 prism diopter base out prism test is negative in both the eyes. The cover-uncover test shows orthotropia for both distance and near in both the eyes. Now the anterior segment evaluation. In both the eyes, the lid position was normal, like the upper lid covers the 2 mm of cornea and the lower lid touches the inferior limbus. Cornea was transparent in both the eyes. Iris is brown in color. Pupil is central, circular, and it reacts to both direct and consensual reflexes. Lens is clear in both the eyes. Intraocular pressure in the right eye is 12 and in the left eye is 10 mm of Hg. Posterior segment evaluation, which is done with the help of indirect ophthalmoscopy, shows there is no abnormality of vitreous, optic disc, macula, or the peripheral retina. Foveal reflex was present and the peripheral retina was healthy. Diagnosis. This is a case of left eye anisometropic amblyopia, and the treatment of my case is a full cycloplegic refractive correction, which is done with the help of contact lenses, and occlusion therapy was advised 6 hours per day, and the patient was followed after 3 months. Thank you.
Yeah, thank you. Will you please stop sharing your screen?
Yes, ma'am.
Yeah, very good presentation, Dr. Sadia, and congratulations to you and Dr. Yogesh also. So I request Dr. Mona ma'am to ask questions to Dr. Sadia.
Very nice presentation, Sadia.
Thank you, ma'am.
As per your examination, your case is anisometropic amblyopia, right? Refractive anisometropic amblyopia
Yes,
because of hyperopia. Okay,
yes,
and there is no any strabismic component. So I just want to know from you how you will proceed. You have just said occlusion. Which grade of amblyopia it is?
it is a severe amblyopia.
Yes.
Uh,
So how will be the tailored approach for this?
The patient had never used glasses or the contact lenses in the past. So first we will give the full cycloplegic refractive correction to the patient, and sequential or simultaneous start of the therapy, occlusive therapy can be started because the patient had never exercised it before. And other treatment modalities like penalization can also be tried.
Is there any role of refractive adaptation? Will you give some time for a refractive adaptation in the initial days?
Yes, ma'am. As per sequential treatment, after giving glasses, after 4 to 6 weeks, we can start the occlusive therapy.
So, is there any additional advantage over 6 hours and 2 hours for occlusion?
Yes, ma'am. For the dense,
severe amblyopia, no?
yes, ma'am. For the dense amblyopia, we should start with the 6 hours per day of occlusive therapy, and we should follow up the patient every 3 months to look for any visual improvement. And if there is a visual improvement, then we should gradually taper the duration of the occlusive therapy. And the end point to stop the occlusive therapy will be the vision in the both the eyes should be equal, and there should be alternate fixation possible. Or if the patient is not improving even after the adequate therapy for 3 to 6 months, then we should stop the treatment. Or if there is any occlusive amblyopia, development of any occlusive amblyopia, then we should stop the treatment.
Okay. Is there any need for additional near vision activities during this patching?
Yes, ma'am. Yeah.
Okay,
Sorry, ma'am, I'm not getting you.
if you are keeping the eye patch for 6 hours,
Yes, ma'am. Near activities should be performed more.
for at
So it
least
should be binocular stimulation.
for at least 1 hour or more. Okay. Okay. And then you will taper, as you say, after 3 months of if there is any improvement.
Yes,
Okay.
ma'am.
Okay. What is the difference between this occlusion and penalization with the atropine?
In
Is there
occlusive,
any endpoint result?
there are certain disadvantages of occlusive therapy, like it is cosmetically not acceptable, and there can be skin rashes and certain things can be there. So
Important compliance is
compliance of the patient is more with the atropinization
okay.
rather than.
But again, there are always disadvantage of both the methods, right? So patching is better always, I think.
Yes, ma'am, it is a
I
gold
will
standard.
highlight it more. Is there any chance of reverse of amblyopia?
Reverse amblyopia can occur in a sound eye if there is if we total occlusion or the complete occlusion for more than 6 hours or the full day occlusion is done.
So you have to always examine the other better eye also.
Yes, ma'am.
Okay. Okay. What is important in this amblyopia therapy? Because there is not only a child role, but a parental role also.
What? Sorry, ma'am. Will you please repeat the question?
What is important in amblyopia therapy as a clinician? What you will guide to your patient and the parent? Is there any role? Anyway, what is the important barrier in the conventional patching? Hmm? Because understanding of the parent is very, very important. The nature of the treatment, the consistency, the perseverance is very, very important in the case of amblyopia. Because many a times what happens, some people do this patching for few days, then again they
Yes,
lost
ma'am.
to it. Okay, so that is very important to counseling of the parent is very, very important.
Yes.
What are the different types of patching and this occlusion therapy you can do? Yes.
Different partial time occlusion or the
Instead this patch. Is there any other type apart from this patch?
microtape.
Have you heard of Banger coil? No?
Sorry.
Yeah, you can directly put on the glasses, no? But you have that in that case you need very well fitted glasses. Okay. Have you heard of photo screener? Photo screener. Any device?
Binox.
Hmm?
I heard of Binox and the dicoptic games and
That is different. That is different. That is to simulate the deprived eye. No. This photo screener is the device where the infrared light is used and the flashlight of the camera is used and the red reflex is captured of both the eyes and compared. Okay. So it gives and it's compared with the normal algorithm and you can know the refraction of the kid. Even astigmatism, hyperopia, myopia, hmm? If there is any squinting. So it is very important to rule out this uh, amblyopia with the organic amblyopia. What is difference between amblyopia and organic amblyopia?
Ma'am, amblyopia is represents the diminution of a vision during
Hmm.
the during the period of visual development, which is secondary to abnormal visual deprivation or the abnormal binocular interaction and organic
Without any structural abnormality. That is important. Okay. And in organic, you can have macular degenerations or any other pathology, right? Okay. Uh, okay. I think we'll leave it to sir now.
Yes. Vivek, sir?
Yeah, so I think she has presented very nice and crisp case, which usually see in our day-to-day practice, right? So sometime, it's like if the examiner is little bit, the tricky, the history which we ask as a leading question, you have to be very particular, which is relevant to the case. If you ask as a kind of, the battery, what is the common template, then you invite sometime a problem. For example, history of, you showed a photograph and there is no drooping of the eyelid. Right. So now your Viva would go to the entire what you anticipated, then that will make you, more anxious while answering where you are anticipating and your mind is not prepared that way. Or sometime it is other way around. So you have read multiple things in depth and now you want to, turn the way you want to give the answer to the examiner. Then you can put those kind of, leading questions and try to revolve around what you want. So now with this kind of, the Viva that Dr. Sunil took, I think you did a pretty good straightforward case and, the answers. So sometime if the resident is very good, then the examiner would ask, go to the level next. Right. So that level next is for me, I would ask again 2 to 3 questions. Okay. So that number one, Dr. Sune has already given you a pointer. You said in treatment, you started glass and 6 hours patching. Is this correct?
Yes, sir.
But is it correct? Is it ideal practice?
After giving classes, we should wait for 4 to 6 weeks for the
Yes.
adaptation, and
Yes.
after that, we should start the.
So you said the glass and 6 hours, so no at a time. So,
Yes.
right. So we have to give at least a time of 6 weeks to really understand, how the child's eye is responding to the prescribed glasses.
Yes, sir.
Then you talk about, mild, moderate, and severe, and then you take a call for, how much number of hours that you want to do the patching. Right. So that's very much there in the amblyopia treatment trial ATS if you read. So I think at baseline the glass prescription and counseling number one. Then when they come at follow up, then you take a call, how dense, what is the severity, and accordingly, as you very nicely elaborated that, the way we practice it. Now level 2, tell me what is the difference between 2 hour patching for moderate amblyop, not severe, 2 hour patching versus 4 hour patching. Okay, no worries, no need to be anxious. Okay, let's move on to the next question. So have you heard about any new instrument which is being used, very recently for treatment of amblyopia?
Binox treatment.
Binox is one of the instrument, right? That's not a mode of treatment. What is the concept behind Binox? I would say Neurasim, not Binox. Then, so that is a virtual reality based, binocular treatment of amblyopia, isn't it? So this is something which is new coming up. Why do you think why the world is, looking for binocular therapy of amblyopia?
Because in amblyopia, separation is there and there is a no binocular perception. So to improve binocularity.
Okay, that can be even little bit more better answer. Romik, you want to take this?
You repeat the question, sir.
Yeah, why we are looking more for the binocular therapy than the conventional patching therapy?
Sir, binocular therapy, like the modern bionics, which involves it might that it will have more cooperation with the child, sir.
Okay, so to improve the compliance, which is the major drawback
Yeah,
of the conventional
patching.
patching therapy, number
And
one.
there will be stigma, some form of stigma also, especially in rural areas, with patching, sir. So,
Yes, so those all group of the disadvantage of conventional patching, we want to solution to improve the compliance and to get the better effect. So apart from that, the concept of treatment of amblyopia has evolved over a period of last 1 to 2 decades. It's not just a kind of the suppression, but there is some sort of interocular, the competitive inhibition. So basically, these binocular therapies, they are trying to reduce or improve the contrast level of the weaker eye by reducing the contrast level of the good eye. And there are a lot of theories that are coming up. It's not just this is dichoptic therapy is one of the mode of treatment of amblyopia. There are a lot of other things, Gabber patches and perception, the concept of perception, competitive inhibition, the monocular viewing in a binocular environment. So that is how those Doug Rush games and the iPad amblyopia therapy that has come into a picture. So basically, the world is trying to find out other ways of treating the amblyopia, considering keeping in mind this non-compliance or the traditional patching therapy. But even at this time point, there is no solid evidence that the binocular therapy would work in a long term. Most of the studies, if you see the literature, they have shown improvement by 1.5 to max two lines over a period of 1 year. But when you withdraw these therapies, then there is a very high chance of recurrence. That's why even till today, I think the patching therapy stands very much good for mild to moderate. And dense amblyopia, we all know that it's very difficult to treat dense amblyopia. Right. So this is overall, I wanted to highlight through your presentation and the amblyopia. I think as a resident, all of you should know very thorough about what are the cutoff levels for calling it, hyperopic, myopic, astigmatic, amblyopias, right? So those are very common questions probably you would been asked by the examiner.
Ma'am, would you like to add anything to it? Mona, ma'am?
Sadia, I just want to know, do you know, as Sir said, the cutoff line for the different refractive errors? You can add that.
Yes, ma'am. For anisometropic amblyopia, anisohyperopia of 1.5, more than 1.5 diopter, astigmatism of more than 2 diopter, and anisomyopia of more than 3 diopter can lead to amblyopia.
Okay. And are you aware of the American Academy of has given some treatment guidelines for this refractive amblyopia or refractive error correction according to the age?
Full cycloplegic refractive correction should be given.
So, according to the age, if the infant is less than 1 year or in 1 to 2 years or 2 to 3 years, if there is anisometropia, so what level of refraction you should give the refraction to the child? At what level? If there is myopia. So if the child is less than 1 year, if the myopia is 3 diopters, will you like to treat?
No, ma'am, because there is a process of e-metropization. So as per that, like when the infant is
No, if you don't know, let it be, no? But you can read it, okay?
okay.
Okay.
Yeah, I just wanted to highlight. I think this Dr. Sune brought out very important point. That's a crux of pediatric refraction and its prescription. By convention, that is called as the preferred practice pattern by AO for prescribing glasses in children. So by convention, they are all values which has been given in those tables. They are by cyclorefraction. So now they have divided, it's very difficult to remember, at least if you don't practice it very often. You don't need to remember. You can put that charts in the examination room, and whenever required, you can go and have a look. So less than 1 year, 1 to 2, and 2 to 3, and more than 3. So as she gave the example of -3, less than 1 year, you don't need to give the glass. Okay, so those values are there, although they are not like a sacrosanct values or rule of thumb, but you can have, a variable practice in different
Right.
part of the world. So what that is a gross guideline to take you a call and take a decision like whether I should prescribe this particular child. So similar example, less than 1 year, 3 diopter, you don't need to give glass. Less than, suppose same child or another child with 5 diopter, then what is the meaning of that? So if the child has a 5 diopter up to 1 year or less than, you can leave that much of, the myopic. But if it is -7 and child is less than 1 year, then you prescribe the -7. That is what the interpretation. Many times, the fellows, they do get confused, but this is what the actual meaning of, those preferred practice pattern. So if child is less than 1 year, -7, I'll give the full glass. Because we know that for that matter, myopia beyond that age limit, if it is any sort of refraction, is amblyogenic to the child. Now, this pattern of prescribing glasses is little bit different in children with CVI. Okay, so in children with CVI, you have to do a dynamic retinoscopy. Okay, and then understand, because they do have poor central fusion. So you have to add on kind of, +1, 2, 3, the single vision or a bifocal glasses to improve their near vision.
Yeah, excellent discussion, and both the topics are very important from the day-to-day practice also, and from exam point of view also. Excellent topics, and congratulations Romik and Satish sir, and congratulations Sadia and Yogesh sir. Both the students, they have done a wonderful job, and a big congrats to their mentors as well. So I think this is time to conclude. I request Dr. Shirish Thorat sir, the president of Maharashtra Ophthalmic Society, to share his thoughts with us.
Thank you, Archana madam. First of all, my congratulations to both presenters, Romika and Sadia, for a very good presentation, and congratulations to their mentor, Yogesh sir and Satish sir also. I would like to thank Dr. Vivek Parkar sir and Monosone madam. They are like soft examiner today as compared to previous uh, PGA webinars. And this is one of the good activity of MOS, where students are getting valuable tips from all experts, not from Maharashtra, for all over India also. And requesting all the students to make maximum use of it and use it to your maximum to update yourself and for your exam purpose also. Thanks to Scientific Committee Chairman Piyush Bansal sir. Many thanks to Dr. Vare madam and Dr. Sumit for providing such a good platform to students. Thank you very much. But it's a very wonderful webinar. Good discussions.
Good stuff. So thanks to our mentors, Dr. Mona ma'am and Dr. Vivek sir once again. And the mentors, would you like to speak something? There's only 1 minute, but still Dr. Satish sir and Dr. Yogesh sir.
I'm thankful. Am I audible?
Yes, sir. Yes, you are audible.
Very much. I am thankful to Vare Madam, Thorat sir, Piyush sir, all the examiners who are here. It was really very nice. This is my first webinar, which I am getting it online. But it was really nice because we are there always with our students, but we have our own limitations. And it's really nice that with such a platform, the students, they are now means they are open to the all this battery of examiners. They are all national faculties. So very
Yes.
nice bunch of questions they are going to get, and we are there always with them. But we are one or two examiners. But hats off to Moss and Vare Madam that on this platform, really the PGs they are exposed to a real exam. Means it's a real exam scenario, and it is helping them to boost their confidence before exam. So yes, the examiners they were also very nice. Means they were taking care that the PGs they are not very anxious, anxiety, and they are teaching also. They are examining them and they are teaching them. It's a very nice blend. Means hats off again to Moss, Thorat sir, and Vare madam. Please continue this, and we will again. We are here. We will again participate in that. Thank you, madam.
Sure, sure.
Yes.
Dr. Yogesh?
Actually, ma'am, I'm thankful for Department of Pediatric Ophthalmology, Sri Ganpati Netralaya for giving us a beautiful opportunity for this. That's all, ma'am.
Thank you. Thank you. So
Yeah, at the outset, I would like to thank Dr. Thorat. I think I am so-called national faculty in this platform, but I am from
Yes, sir.
Maharashtra, and I always enjoy being a part of any activities in MOS, WOS, and my own state, the district, that is Buldana Ophthalmologic Society. So I think it's a very great initiative, Dr. Thorat, that helps the residents to really build up their confidence. And in a retrospect, they always feel okay, that question was being asked, and they don't feel anxiety when actually they face their viva. So I think this is a really a great initiative, and probably other states also they should emulate to really improve the residents' performance during their exams. Thank
And
you so
these
much.
videos are available on YouTube. So later on also, if
Yes.
they can't watch, but later on also they can watch recorded videos. Okay.
Thank you. Thank you, everyone.
Thank you.
Thank you,
Thank
sir.
you, sir. Thank you,
Thank you,
madam.
madam.
Thank you. Bye bye.
Thank
Take
you.
care. Good night.
Bye bye.